Great. Thank you so much, Jason. So we have a few topics that we're going to run through today, starting with Medicaid unwinding, then we'll touch on reprocurement, and then Medicaid expansion is the last topic for today. So Erin, next slide. So Medicaid unwinding, this is really, as you guys are seeing day to day in your facilities, really a code red situation that we're encountering. As Robin has worked continuously on education and next steps for this process, we are in the midst of sort of a massive loss of coverage for Medicaid beneficiaries. So when COVID initially hit in 2020, the public health emergency enacted the continuous enrollment provision, which kept Medicaid eligible beneficiaries on Medicaid for the duration of that PHE. As that expired in March of this year, CMS has tasked all the states, including Georgia, to initiate the process of reestablishing Medicaid eligibility checks and running that on its normal cycle of verification. And so, through that continuous emergency enrollment provision, from 2020 to 2023, when that ended, there was an increase of over 22 million nationwide who maintained Medicaid coverage. So we anticipated that this was going to be a rough re-entry into that process. So as we had touched on, Robin has been in constant contact with the CSBs about managing this process. To date, the latest numbers from Georgia is that 324,000 beneficiaries have been disenrolled. And Mike, those numbers were through August, I believe?
September the 30th.
Which is more than 10% of the total enrollment here in Georgia. So the original estimate for the entire unwinding process was that we're going to lose 12 to 20% of the Medicaid population through this process. For us to be 4 months in and already losing nearly 12% of that coverage makes us very concerned about, what the next 8 months are going to bring. Next slide. So Kaiser Foundation has been doing what we think is a fantastic job of tracking monthly renewals and reporting on specific state-based data. So their latest grid as of September 2023, talking through the state of Georgia. So the different blocks here, we have a couple different things happening. The bright blue block is renewed on an ex parte basis. We'll talk a little bit about what that means in an upcoming slide. The tiny blue box is what is renewed via renewal form. That's a standard process for verifying eligibility. The big concern here is that big orange box that we see in each of the months that they've been doing it, where terminated for procedural reasons. Tiny orange, which is a very small portion of each of these, is someone has been booked ineligible, that they've gone through the verification process and they've lost eligibility. And then the gray blocks is the renewals that are still in process and that the state is still working through. Next slide. So of the disenrollments, touching on what we had just looked at, only 14% have been due to people actually losing coverage. And those beneficiaries may be eligible for other coverage, whether that's Georgia Pathways to Coverage, whether that is exchange eligibility, but 86% of the disenrollments have been for procedural reasons, likely lack of member feedback. 35% of the overall reviewed population has been termed for those same procedural reasons, and only 6% of the overall renewals have been termed for ineligibility. So 26% of Georgia's population still pending renewal. Next slide. So We had touched briefly on an ex parte renewal. So that is one of the tools that CMS affords every state to attempt to keep people enrolled in Medicaid and CHIP if they are not able to get all the information they need from the beneficiary themselves. So states have the ability to use other information that are available to them, like state wage data, different things that are reported to the state to conduct an ex parte renewal. But in late August, CMS identified a concern that was potentially leading to minor children being disenrolled inappropriately that was very concerning to them. So there is a programming error in several states, we believe Georgia is one, where these renewals are being looked at on a family basis and not an individual basis. And as you guys likely know, in order to maintain minor coverage, it's much less of a burden to clear than adult coverage. And so if they are looking at these renewals at a family level, children who are still eligible are likely losing coverage when they shouldn't be. So data that HHS has released says that 74% of children who have been disenrolled actually remain eligible. And these kind of administrative failures are a key reason why. So we really, what CMS has asked all the states to do is to pause procedural disenrollments for those individuals impacted by this issue, to reinstate the coverage for affected individuals, to work with CMS on a mitigation strategy that fixes that issue going forward to prevent the massive loss of childhood Medicaid coverage that should still be in effect. Next slide. And so CMS also remains gravely concerned about the sheer number of procedural disenrollments that have occurred. Nationwide, 71% of all beneficiaries who have lost coverage were termed for procedural reasons. So what does this mean? Enrollees may not have received the renewal notice. They face barriers to completing the redetermination process, including not understanding what it is they're supposed to be doing. Eligibility workers may have actually received the requested information from a beneficiary, but the case was closed before that information was renewed. So state ranges are pretty significant in terms of what we're seeing. For instance, in New Mexico, 97% of all disenrollments have been for this reason. But in a state like Oregon, only 4% of their disenrollments have been for this reason. Unfortunately, Georgia is near the top of that range, with the 86% of our loss of Medicaid coverage being for a procedural reason, not actual loss of eligibility. We have heard, but have not confirmed, that CMS is working with states that are at the higher end of this range to try and slow or halt the process of continuing with redeterminations. Mike, Robin, have you guys heard anything in the last week? If there are any additional updates on this?
Well, I thought as of the beginning of last week, Robin, that I believe Devin had called over there and determined that they were not stopping, that they were slowing and maybe granting more time to go through membership response process, but they had not stopped the process, which was concerning. Robin?
Yeah, the information that I got when I touched base with someone at the Department of Human Services was that they had not received an order to cease and desist as of now.
So disappointing, but definitely something that we're tracking as the state continues to process those enrollments. Next slide. What should providers do? If they've slowed the process down, really, what are the next steps? For those who did not respond or were disenrolled, for those who did respond and were legitimately determined to be ineligible, those who have yet to be reviewed, and those who were renewed on an ex parte basis. So the potential response for sort of this gamut of different scenarios that can happen if they were disenrolled for procedural reasons, education on appeal process, which we'll touch on in an upcoming slide, provide assistance if available to walk through the appeal. If they're legitimately ineligible, educate on if Georgia Pathways to Coverage or the health exchange is an option to pick up coverage through another special enrollment period. Skip that one. For those yet to be reviewed, I know that Robin has presented on this. Post the notifications in your intake areas regarding the state review process, potentially mail education on the revalidation process to your Medicaid and CMO patient population. Next slide.
Yeah, we have kind of this wide range of business offices, you know, with our hospitals, practices, and you guys, that on one end of the spectrum, it's pretty much just kind of wait and see what happens and just, you know, see who falls off the rolls. I mean, at a minimum, the obvious point is if they're going to be doing disenrollments at the end of every month, that the pre-authorization process and the insurance verification process is huge. You can't assume that a patient that it was on a Amerigroup last month is still on with them for this month. That's a given for the next probably rest of this, you know, until May of next year when the process runs out. But beyond that, you've got the ones that mailed out everybody that was in Medicaid, not just CMOs, but Medicaid, um, for the last 12, 18 months. I don't know how far back they went, Kelly, and just mailed something to all of them saying, this is what the process, revalidation process is going to look like. And this is what the appeal process is going to look like. If you get any, you know, please respond because your coverage is at risk. And then all that. That's probably a pretty costly version of reaction to it. However, you know, I'd kind of argue that, you know, if 20% of your Medicaid population rolled off to straight self-pay, that's probably a fairly significant financial hit going the other way as well. So, you know, it's almost like you can't undereducate. There's anything you do is going to be beneficial. Kelly.
Yeah, and that really touches on the next slide. You know, obviously to refer back to the GACSB Medicaid unwinding presentation from April, where Robin had pulled all the resources together that DCH and other agencies had provided, the Medicaid unwinding partner toolkit, the flyers that can be used for patient education, enrolling, reminding members to update their contact information, which is a big one we've seen as a hurdle under the Gateway portal to ensure that they are getting these renewal notices, understand what's required of them. Next slide. And so for really the procedural disenrollments, the 5 steps to appealing those determinations, you know, to identify the denial reason in the letter, request a fair hearing within a certain period of time, get the date, provide all the evidence of why you're still eligible for coverage, and then wait on the decision. But, you know, obviously, as you guys are checking information, when you are intaking beneficiaries or patients, that may be the first time that some of them have learned that their coverage has lapsed if Georgia has not been able to get in contact with them. So having resources available to direct them to the appeal process is going to be critical for those intake staff. Next slide. So Medicaid reprocurement. So just as a background, you guys are all well aware of the history of how we got here. Georgia moved away from just a traditional Medicaid methodology in 2006. So we have been at this for 17 years, going on 18. And those first contracts really stayed in effect in the market for 9 more years. In 2015, Georgia initiated its first reprocurement. And we moved from our original 3 to 4 CMO carriers, which was a very beneficial process in bringing more balance to the market and the opportunity to revisit a lot of what we learned in the first 9 years of doing this. The hiccup that we had following that procurement as Centene purchased WellCare is that then we're back down to 3 CMOs. And in terms of who is really controlling the majority of those lives in the state, it continues to be Peach State post acquisition of WellCare. And so we're in our 3rd procurement cycle now, which feels like it's been going on, Rob and Mike, 6-7 years at this point.
At least.
So next slide. So, this is some recent data that DCH has released in terms of overall Medicaid population coverage and relative cost of payment. They really have 4 segments that they break it out into: your ABD population, your low income Medicaid, and your Peach Care for Kids and respective cost. As we have talked about, the population that are in the CMOs tend to be the lowest cost to Medicaid overall. Your age-blind and disabled population, total per member per month for that population is hugely higher than your Peach Care for Kids or your low-income Medicaid population that are in the CMOs. And so we'll touch on this and the importance of it as we talk about what has come out in the RFP. Next slide. So what are some of the key dates that we're working on? Obviously, the RFP finally opened from Department of Community Health on September 22nd. Responses are due back to DCH by December 1st. So these next 30 days is really the crunch period in wrapping everything up for the prospects and incumbents to submit their bids. The state has said they intend to make the notice of award in May or June of next year, with the new contracts to take effect on July 1st, 2025. Those contracts will be on a 1-year initial term with 6 1-year optional renewals. Next slide. So in the RFP, DCH notes that they intend to award up to 4 contracts. So Mike, do you want to weigh in here on what you guys heard from some of the prospects at the recent conference?
Yeah, well, I guess there's 2 versions of this. One is that you were about to report that in the bid, it does make provision for the ability to add in the ABD population and low income Medicaid population. That's one thing. The feedback that I got in talking to some of the prospects was that they don't really believe that's going to happen now, although it's still in the bid, and that's not a step that the state's willing to take anytime soon. Maybe some small pieces of it, but not overall. I know you'll talk about 360 in just a second here as well. But I think the consensus is the state says up to 4. The definite rumor mill is that the state's really not willing to unseat an incumbent due to the disruption of having to take a population of 3 or 400,000 member population and flip them over to another carrier. Thus, you're sort of left with the incumbent staying put and adding a 4th one that gets a lot of the new enrollment in order to build up their base. And so that was kind of interesting feedback because it kind of ran a little bit counter to just a straight read of the bid that Kelly's about to walk us through.
The Georgia Families 360, which is the foster children population in the state, that contract has historically been with Amerigroup. So we believe strongly that DCH is going to transition that. Not all of the prospects or incumbents, we believe, are bidding for the foster care population. One who definitely is Peach State, and from sort of the winds that we've heard and the news is that that population is very likely to transition over to Peach State from AmeriGroup. And so, as Mike had touched on, the RFP does make allowances for the other more traditional Medicaid populations to move in to Medicaid managed care. While it seems like the state is still deciding on how they're going to roll that out or if they're going to roll that out, this is the first time in any of the bids that have been released where they are providing for that eventuality. So that is something that could change over the life of the coming contract. Next slide. So in terms of really what we've been able to discern, and I'm sure as you guys have heard from the presentations, you know, at the conferences and from you know, both the incumbents and the prospects, you know, maternal mortality and morbidity, that is definitely a huge focus area for Georgia. But behavioral health is a huge one. So, you know, looking at comprehensive and integrated behavioral health services, as well as value added services that allow the right service at the right time for each member. So integrated physical and behavioral health, working with other providers in the spectrum, focusing on social determinants of health. So, you know, there have been various conversations about what a value or incentive-based mechanism is going to look like for behavioral health. That is definitely a priority that is going to be coming in the next contract. So, you know, I don't know that any of the prospects or incumbents have the exact model that they're going to be pursuing. But, you know, as we look at this being introduced over this next contract cycle, the biggest piece that we've always said is that these need to be value add dollars. They're not a replacement for fee for service. They're not a replacement for the day in, day out services that you are providing to these patients. All of that revenue and that incentive has to come over the top of those dollars. Mike, Robin, anything to add there?
It's obvious that as we've talked to them, and Robin, jump in here, that nobody really comes to the table. Like on the primary care side, they already have sort of pre-built models that exist in many other states. But the closest to it, I believe, is Molina, but we just really haven't had conversations with them. It's all, will work with us and help us develop something rather than here's our, you know, deployed over 2 million lives across 7 states. This model is tried and true, and we really believe this is one that comes down to it. It comes all the way down to how do we know which patients to hold you accountable for? How we do attribution for a primary care member. They either select you or you're the one that mainly sees them. On the behavioral health side, you know, yeah, CCBHC kind of concepts help with that, but they still struggle with, well, how do we know how to assign you a set of patients in the first place when they can go to multiple providers? Robin, add to that, thoughts?
Yeah, I think that with the state plan amendment being crafted by DBHDD and DCH to go to CMS, that's you know, been approved by the DCH board. We'll get an update on the state plan amendment later today during our 3 o'clock meeting with DBHDD. But with the language written into this procurement bid or this procurement RFP as it relates to behavioral health homes, and the language in the state plan amendment regarding behavioral health homes and CCBHCs, that's going to open the door for the managed care companies to come back to the table. But Mike's right. They haven't really come to us. We've had some really robust conversation with Molina. We previously had some pretty robust conversation with CareSource on a value-based model, but then they kind of pulled that back once the procurement conversation started, because I think that they're honestly trying to work on something a little more robust, to be able to offer, but it just has not been, nobody in Georgia has really had the pathway to move forward, like Mike was explaining, as it compares to the primary care side and those lives. But I think there's definitely a lot more that we will see.
Next slide. So for the Georgia Families Program, there are some specific components that they're looking at: severe and persistent mental illness, substance use disorders, chronic behavioral health conditions, and really looking at establishing a behavioral health home similar to, again, the primary care home model that exists on the medical side. It's looking for the contractors to include and meet all the DBHDD requirements. And then one note is that behavioral health providers, they are looking at, initial, quarterly, potentially more frequent summary reports of behavioral health to the members' PCP, and what that process is going to look like, and ensuring that how that's going to work. And then that the contractor and DCH, again, are going to work on that value-based program model that aligns with the Georgia family goals. Robin, Mike, anything to add to those?
I don't.
No, I don't have anything else to add, Kelly. Thank you.
And then chronic disease management is another huge priority for the value-based component in this next cycle. So next slide. Mike, you want to take this one?
Well, it's almost since day one, there's been a lot of interest in this reprocurement, and you have a mixture of in the prospects. You have a mixture of governmental only players like Molina and AmeriHealth Caritas, and then the existing commercial carriers. And again, this is just to restate the obvious. In a state like ours, where Blue Cross on the commercial side has such a pricing advantage and thus a 2/3, 3/4 market share, all the other carriers who want to play in Georgia are sort of left fighting over health exchange, Medicare Advantage, and Medicaid. And so really doesn't come any surprise that most of the other carriers in the market would want in to try to play in the Medicaid world. And so we've been in discussions. I guess flip to the next slide. And Kelly, I'll take this one and then you color commentate on me. The discussions, we've been having discussions with these guys for, a year now or what have you. It's been a very long time. And I think y'all know our intention was to pull everybody together into one single footprint that wasn't just y'all, it wasn't just our hospitals, physicians, it was everybody in one thing that we called SHPPN, cleverly SHP Provider Network, just to have something to take the totality of all y'all to all of them. And I'll do the prospects first. So we kind of launched all those discussions with them with an idea that there are rates, and we can't talk about details of, but there are rates and specific language items that you would like reflected in your contract now, because our experience has shown us over the last couple of reprocurements that once the bid gets awarded, everything kind of defaults to Medicaid at that point, or we're kind of at their our leverage goes away at that point when we know that Aetna's the winner. Aetna's stance building their contracts kind of gets a lot tougher. And so with all these guys, all the prospects go to market with the letters of intent that they would like for you to sign. All of them are very generic, all very non-binding. They all check the box for the purpose of showing the state that they are attempting to build a network. And so it does sort of, it accomplishes that. If you choose to want to sort of vote for Humana, for example, it does give you the ability to say, yeah, I think Humana would be a good partner. and therefore I'm signing off that I'm willing to do an agreement with him later on, and nothing is binding now. The problem we've had with that since day one is what I just said, which is our ability to have any leverage in that discussion with Humana exists when they're bidding against everybody else versus when they're awarded on the back end. And so, yeah, it is non-binding. However, it you know, our thought all along had been that your leverage exists now rather than later. And so our preference was to go ahead and try to nail those points down. And so the whole process now has been to work through the letters of intent that included those things with them now, with an idea that those would then flip to full contracts post bid process. But when there was time after the bids were in to work through translation of that into full agreements. And so you see down the way there that we're somewhere in the process of that with each one of the prospects, with the exception of Centera. Centera is late to the game CMO prospect that is out of North Carolina, Virginia area that just simply popped up too late. And we just fail to see that there's any way that they're actually going to get a footprint to do anything right now. So in the midst of all those, for everybody participating, you've been messengered out what the rates were that were offered, and had some feedback related to that. And so we've been working through that. Now with the incumbents, it's the knowing again that you guys have, that the group has sort of stuck together. AmeriGroup really, has not pursued an agreement at the larger footprint level, and they're pretty clear to us that they're coming back to you guys individually, because even the incumbents were told that your existing agreement is not justification that they have a network, which is weird, but it's true, but helpful to y'all. They have to have these letters of intent signed as well. And so if you're getting door knocked from AmeriGroup, CareSource, and Peach State, that's why. Because the fact that you're already contracted with them does not serve as proof that you will continue to be contracted with them post when this bid goes into effect. And so that's why they still need you to sign something. And so with AmeriGroup, they've been pretty clear with us that they don't want to work back through the full footprint, that they're approaching you guys individually. And again, it'll feel like it's non-binding and there's nothing to the LOI and it's all sort of very cursory. But again, we think especially with the incumbent, signing that is kind of a vote for them. And if you want to vote for them, so be it. However, we think that there should have been in theory, there should be a price to pay for that, and that's what we've been kind of holding out for. With CareSource and Peach State, after a lot of kind of rolling tumbleweeds, they finally have come back and re-engaged those discussions, and we're awaiting both to give proposals at the SHPPN level that have CSB implications to them, and certainly we will evaluate those and get those out to everybody when we get something tangible from them. Kelly, Robin.
No, I think that gets it. Robin, anything else to add from your end?
Nope. Think we're good.
Next slide. So as Mike had touched on, big push right now as we get close to that 12/1 deadline. So the payer push for LOIs, again, an LOI is a vote for the bidder. We think that AmeriGroup is certainly going to be pushing hard over the next couple weeks. Time continues to be on our side, not their side. And so, general thought, what is the payer giving the provider to justify that LOI versus a need to acquiesce to their own timeline requirements and payer pressure? Next slide. A couple things to consider for anyone that is, coming at you guys directly, and things that we've been working on, again, in ensuring that all the LOIs have these protections for the providers, that you can continue to provide all of the same services that you do. We tend to see once the contract's in place that they want to carve out specific services, and if you provide lab services or other services that they can send out to another carrier, that you're maintaining the ability to provide everything that you provide to your entire patient base. that, you know, there's a commitment to the same code set, service definitions, practitioner levels as DCH, DBH, DD. Adding new codes and services as they are added by DBH, DD, and DCH, that contract and reimbursement rates can only be changed with signature of both parties, that there's no unilateral ability for them to change material terms and material rates that will impact their performance of the contract. That the payer is committing to utilizing fair payment policies and pre-auth policies for for you guys specifically. The big focus is limiting any pre-auth services to CSU, ACT, and IOP as examples that minimize that administrative burden and allow you to use your time to provide services, not managing the administrative burden of any of the carriers. So with the next slide, we'll be moving on to Medicaid expansion. Robin, Mike, anything to add before we touch briefly on this?
No, that's got it.
So Medicaid expansion. Georgia in July of this year finally rolled out their version of expanded Medicaid. As you guys remember, when the Affordable Care Act took effect 2013, 2014, one of the key components of that legislation was for all states to expand Medicaid eligibility. So based on Supreme Court decision, that did not happen. Only some states expanded eligibility for population. So Georgia was not one of them. And we've continued to have really this donut hole of coverage where between qualifying for low-income Medicaid as it exists today and qualifying for premium subsidies on the healthcare exchange, which doesn't connect until you're at 100% of the federal poverty level. So if you're somewhere between like the 25% of FPL for low-income Medicaid and 100% to qualify for exchange subsidies, you don't really have a path to coverage. It's estimated right now that about 250,000 Georgians fall into that coverage gap. So this expansion anticipates that some of that eligibility gap is going to be closed. So it's available to U.S. citizens or legally residing non-citizens between the ages of 19 and 64 who have a household income of up to 100% of the federal poverty level. You can't otherwise qualify for Medicaid, you can't be incarcerated. And really the key component that Georgia has done is you have to document that you're meeting this qualifying activities threshold, what has really been referred to as the work requirement. So following Medicaid unwinding, you know, the overall enrollment and pathways to coverage could really look different, but right now the state is anticipating that about 100,000 of that 250,000 donut hole will qualify based on the qualifying activities threshold. Next slide. So really, what are the qualifying activities? Full or part-time employment, being enrolled in on-the-job training or in a job readiness assistance program, engaging in community service, training for a vocation, enrollment in the vocational rehab program with Georgia or other higher education. So you have to meet 80 hours of that every month. While there are some, like enrollment into a university where you can document 4 semesters at a time, there's concern that the rest of it has to be monitored and re-verified on a month-to-month basis. So if you're providing community service, submitting those hours every month, concern about DCH resourcing that and the ability to monitor that, potentially leading to retroactive disenrollment. You know, we'll know more once the program has been in effect, because really the first coverage decisions are starting to come out now, but it is definitely something that we're monitoring for, you know, potential coverage, loss of coverage, loss of coverage. Next slide. So Georgia did make the decision that Pathways to Coverage is going to be enrolled into the Medicaid managed care. So Amerigroup, CareSource, and Peach State as it currently stands. And for any coverage differences, benefits are the same as traditional Medicaid, with the exception of if you are in Pathways to Coverage, you will not have non-emergency medical transport available as a benefit. So what do providers need to do? Educate patients or guarantors on program, eligibility requirements, and sign-up mechanisms. Next slide. Mike, you want to wrap things up?
Well, it's just a lot, with all three pieces, there's a lot of moving parts that are still kind of up in the air, and we'll continue to monitor it for them. Robin will get the information out to y'all to the degree we have kind of enough of a pile of stuff like this that we'll schedule another one of these and give everybody updates on it. It's just, especially as the bid process moves forward on the CMOs, we will, keep everybody abreast of that. Certainly to the degree they start messing around with the adult population, then we understand there's tons of implications on that we need to think through together. Robin, anything to add?
I don't think so, Mike. I just would really like to say a big thank you to Kelly for presenting all of this information and pulling it all together and getting educated to be able to present it to the CSBs. Appreciate 64 folks joining today. We have tried to keep you abreast of the moving parts on all of these things, which completely has a direct impact on the CSB book of business and your communities. We are here to provide resources as they become available, and certainly happy to take any questions.
Yeah, if you have any questions, feel free to use the chat. I see Sonia Davis. Aaron just answered your question, but there's a chat box at the top there you can access, or again, raise the hand icon and we'll unmute you. Okay, I see one there from Katrina Wheeler. Any updates?
I'm happy to take that one, Jason.
All righty.
Yeah, so on the behavioral health rate increases, no update until we get to the legislative session, because that's the next phase that it has to go through. It has to be approved and allocated by Georgia General Assembly before it can go to CMS for approval. So that is not something that's going to happen immediately, and that's what we keep pushing Commissioner and DBHD on alternatives to helping the CSBs as we await for the behavioral health rate increases.
All right. Any other questions before we wrap up? If not, as Aaron answered, the recording along with the PowerPoint slides themselves will be available today or tomorrow on our website, where you'll be able to access them. And of course, how to find us, how to find Robin, Kelly, or Mike if you have any questions going forward, and we'll be sure to get them all addressed. And if there's nothing else, we can all stay warm or get warm. Enjoy the rest of the day.
Thank you.
Thank you, everyone. Yeah.
Bye.
Bye-bye.